Okay, so hello everyone. My name is Chastka, and I'm a physical therapist at Ladybird Physical Therapy. I'm a pelvic floor PT, and I'm super excited today because we have Sha'Rose Erion here, and we are going to talk about surgical care and gender affirming care. And so I'm super pumped to talk about this today. So if you don't mind, can you introduce yourself? Tell us a little bit about you, how you got into pelvic health, all that kind of stuff.
Yes, thank you, Jessica. I am so excited to be talking about this because this is like my baby, Anyway, so I am Dr. Sha'Rose Erion, as Jessica mentioned. I am owner of Rose Pelvic Physiotherapy in Huntsville, Alabama. And a little bit about me. I'm originally from Florida, born and raised there. I am a Miami Dolphins fan. We did make it to the I wish it was a Super Bowl. We made it to the playoffs after 20 years. So I'm very excited about that. Anyway, so yes, from Florida, and I have my lovely husband that I met there, and then my two little ones. I went to the University of South Florida in Tampa for my undergrad, and then for my graduate PT degree, I went to the University of St. Augustine in Austin, Texas, and it's kind of yeah. So I'm familiar with Austin.
There you go. Very cool.
Yeah, and so I got into kind of like pelvic PT. So I had an idea. I knew I was going to go into physical therapy out of high school, but then I was like, okay, pelvic PT. I kind of got into that when I was in the middle of physical therapy school, and I had like a slight idea. Had heard about it. We had like 2 minutes of pelvic therapy in school. And then I had my son in the middle of school, and it was, perfect delivery and postpartum and pregnancy. However, my OB at the time was like, hey, you can go back to doing all the things that you were doing before. And I was like, yeah, okay, that tracks. And then the awesome physical therapists around me, who were my professors, were like, yeah, no, you probably shouldn't be moving a whole apartment when you're like 10 weeks postpartum. I was like, oh, no, that makes more sense. And they weren't even pelvic PTs. And so then I was like, okay, maybe every pregnant or postpartum person really could use a pelvic PT because, the information just isn't there. There's no one telling you what you should and should not be doing in any type of way. So that's kind of how I got into pelvic physical therapy.
Yeah, and then tell us, how did you niche down into gender affirming care?
Right. So that kind of was going on in the middle of me just learning that I wanted to go into pelvic PT. So I've always been a part of the LGBT community and friends and family members. And so I would see people going and having procedures or surgeries, and I would just be like, well, why, how are you not doing anything before or after? Like, I know you have whatever dysfunction going on, but there's no one kind of addressing that part of it. And so kind of piqued my interest. And in my last year of PT school, I did a research project where I write a research paper, but then also do like a 15-20 minute presentation. And I chose the subject of how can pelvic floor PT assist with gender affirming care and surgeries. And as I was literally like putting all this stuff together and going through other resources and references, I realized, one, how challenging it was and how few actual resources there were to give you some idea of what a pelvic PT or any PT really could help in that surgeries or procedures. And then the other part was how the access to it, because I had all the things open to me because I was in school. But if I wasn't, I don't know that I would have had the ability to see some of the things that I was able to see. And so when I, put together this presentation and I give it, and our program director at the time, he was like, I've never in my decades of being a physical therapist gotten this information before. No one is talking about this. No one is doing this. And I hope that you continue to, and I hope that people continue to. And
yeah.
So, yeah.
Awesome. I love to hear that. I mean, it's we all think that our job, we're helping so many people, but you're helping such a population that doesn't have a lot of options for help. That right. There's not enough pelvic floor PTs in general, much less that know how and can treat the LGBTQ community. So that's amazing. But okay. All right. So if we're talking And I guess like one thing that we mentioned, like when we were marketing, just talking about it, but it's like this webinar specifically is like surgical management of gender affirming care. That is obviously not all encompassing for gender affirming care or for the LGBT community, but that's what this is going to focus on. And maybe we can have you back to talk about that otherwise. But non-surgical. Yeah, and actually one of my questions is non-surgical because I just couldn't help it. So we'll see if we need to like boot it to later. But okay, so I guess could you start by maybe, and I realize you can't give us maybe a whole complete list, but what are some typical surgeries that you see or that you know a lot of pelvic floor PTs do see? So let's start with that. What surgeries?
Right. So surgeries, and I'll say surgeries and procedures, right? Because some of them aren't necessarily surgical, but they are some procedures and things like that. So for sure, when we talk about top surgery, that can look a couple different ways. So if we're talking about anatomical male at birth versus anatomical female at birth, we're talking about either removing chest tissue or adding chest tissue. And so that is an area that you could be seeing a patient come in with, or that you could be assessing a patient with. And so that is one of the areas, as well as if we talk about bottom surgery, right? That can look a multitude of ways. When we talk about bottom surgery, we can talk about any type of like a meta, which let me think, metoidoplasty, there we go, which is like, okay, if we're talking about anatomical female at birth, we're lengthening the urethra and we're doing things like that to not necessarily, it's a procedure, it is a surgery, and there are some other parts to it. We could be
You said
talking.
it's not a surgery to lengthen the urethra?
It is. It is. Mm-hmm.
Oh, okay,
Yeah, yeah. But the other surgical parts to it.
Yeah, yeah,
Wow,
sure.
what a great procedure. No.
Yeah.
But then we could also be talking about phalloplasty, which is making a phallus, vaginoplasty, where we actually make a vaginal canal. So there are multiple different surgeries, and each of them have a pelvic floor component to it. Even when we're talking about top surgery, there is still a pelvic floor component because whatever you stack on top of that pelvis, right? We want to make sure we're still addressing that. And then any type of procedures, and I say that because it could also be any flap procedures that might happen. So if we're talking about creating any phalluses, right, we could be having forearm areas that are impacted, as well as maybe the thigh, and then maybe the back as well. That's not, but it could be something that is that you might see.
Yeah.
Dealing with gender affirming surgeries and procedures.
Okay, so that makes sense, like kind of top and then bottom, and there's a lot of different types of different bottom surgeries just depending on all kinds of different factors, I would assume. So I guess in my brain, I kind of think like preoperative, I think super acute, and then I think like after surgery. So preoperatively, if we can we go by, would it make more sense? Like I think let's go preoperative top, preoperative bottom. Does that make sense?
Yes.
So that's my question. Yeah. Okay, so
yes. Let's break it down for my brain.
Yeah, let's break it down for my brain. Exactly. Okay, so preoperative top, first of all, do you see that, or is that something you would most likely see afterwards?
That is most likely afterwards.
Okay.
I've had one patient reach out to me that hadn't had surgery yet, was planning on having chest tissue removed, but was preparing because like they were going back to a heavy duty job and was like, I know I'm going to have to lift in, I don't know how many weeks. How am I going to do that? So that was kind of the one off, but usually it is post-op that I'm seeing.
Okay. Go ahead.
No, sure.
Well, I was going to say, like, in a perfect world, if you were seeing them preoperatively, do you have in your mind, like, oh, I wish they could work on this, and that before? Or is it like, no, it really makes the most sense just to see them after in most cases or something?
I would love to see people pre-op and just like talk about the things to expect kind of more acutely, right?
Yeah.
Like these are the things that you may be preparing for. So it is still preparation for a post-op, but it's still like pre-op. Like, but also let's see where the tissues are now. Let's see what mobility we have now. Let's see how the rib cage moves. Let's see, what is our shoulder and arm range of motion now, so that we know what your normal can be or could be post-op. So it's kind of like a test retest, right? Let's like see what they are now and retest it later and see if we have any more of that or any less of that, and try to figure out what your normal will be afterwards.
That makes sense. That makes sense. Just to like, if there is a restriction, you can start working on it, but it's like also, like your baseline. Let's see. What about, I would assume it's more complicated, but what about preoperative bottom surgery visits? I guess like maybe what do those typically look like? Like what are you talking to them about? What are you like assessing? That kind of thing.
Right. So if we've been working and we knew that bottom surgery was going to be in the future or something that is already planned, then we've already been starting to talk about that kind of acute post-op, what we're expecting. But we're also addressing any restrictions. We're addressing any type of breathing. Breathing is a big one, right? We use breathing for so much stuff. It is one of our most basic and just like fundamental movement patterns that we have. And so we know that anytime that we are having in a surgery or procedure that's going on, if we're having this in the bottom surgery, how are you going to be able to breathe and move when you take a deep breath that might just not be comfortable? Right. And we also do that I guess I should have said that for top surgery too. But anyway, so it works for but it's really, big. Like, how are we going to be able to take those deep breaths when we know there is that component of the pelvic floor movement that happens when we breathe, when you're like, I don't want to do that because it hurts and is uncomfortable. So that's something that we start going through pre-op. But then if we're working on anything already, if we know that there's any type of pelvic floor restrictions that we've been working on, any type of pelvic floor laxities, any discoordinations that are there that we've already are aware that are there. And now we're like, okay, do we know there's going to be more of this afterwards? What are the things that we can kind of get you to a place where you are comfortable now, and there may be a slight difference in your recovery than expected because we're already going in with some other pelvic floor dysfunctions beforehand.
I was just about to ask this, and I think I know the answer, but I just kind of am going to check rather than like assume. But like, I would assume like you've never been like, oh my gosh, this is so much tension. Like, I think you need to delay surgery. Like, like, have you said that before?
No,
like,
I mean, while we part of it is like we would tell someone that maybe in general, right? We would, right? We were like, I really don't think this is a great idea. There may be this restriction, and it might not be a great recovery. But this is a little bit different. When we know some of these gender affirming surgery procedures, they can be life-saving. And they are planned out years in advance at times, where it's like, I have the means, I have the ability, I have the time off from work, whatever it is to do this. And while my pelvic floor or abdomen or hips or whatever it is may not be in a place that we know there's going to be something after we need to do, we're still going to do it. Right. And so
that makes sense. It was just,
Like, in an ideal world, no, don't do it. Please, let's work on this stuff beforehand and like, let's put it off. But, in the real world where it's just like, this is an opportunity and this may not come for me again. Okay, let's work with as much as we can and get to where we can. And then we'll figure it out afterwards.
And then in your like preoperatively, do you feel like you would like, I would assume, again, so I'm going to clarify, do you feel like people are usually like more tense versus lax or weak?
Yes.
Like, I would assume, generally speaking,
that's why everybody needs to breathe. And needs to breathe the right way.
That's fair. It fixes
take a big breath, right?
Yeah, everyone take a big breath.
It is true. We generally have more pelvic floor tension and restriction than we do laxity or that is true. However, we can have a tight and weak pelvic floor, but generally it is that restriction. So we're really working on ways, how can we release some of this, because we know post-surgically that tissues are going to be a lot tighter. We're going to be working through some more restrictions there.
Do you find it complicated, like as a provider, being like that there's so many different types of surgeries that you're like, okay, you had this one, like what are the precautions for this one? Or do you feel like usually the patient brings back like little form? I don't know. Like,
oh no, no. Honestly, there usually are not procedures. And you're kind of like, all right, where am I falling back on my just general PT knowledge of post-surgical, and then where am I falling on my pelvic PT knowledge? and then mixing those, and then, oh, that's something new. Well, let's do a little research on that, you know?
Yeah. No, that's fair. That's fair.
So that is where one of the things that I did when I was preparing and knowing that I was going to go into gender affirming care is I took a course through the APTA, which was just like, how do we treat anyone, right, in gender affirming care? But then I also joined WPATH, which is the World Professional Association for Transgender Health,
Yeah.
which subsequently has the US. And so that is really just a network of anyone and everyone who is treating any type of transgender, non-binary person, and where you can come and you can ask questions, and it could be anyone from a urologist to a psychologist to really anyone who is in control of care,
Mhm.
but where you can ask a question of like, hey, this came up and I'm not really sure how to handle this, or have you seen this before? And just kind of a network of people. And each year or every so often they have their standards of care, and right now it's version 8, the standards of care, which is just like, this is how there's kind of procedures for treating some specific conditions and things like that. That's global. Everyone is on the same page that by these standards of care, this is what we should be doing. So sometimes that does come and help out if it's like, I'm not really sure what I might be wanting to do.
Sure. No, that's really interesting. That I didn't know that existed. So I'm like, okay, I'm gonna go check that out later. That's fascinating. Okay. So preoperatively, then do you usually, like, I think of sometimes how I see like birth prep kind of visits. Sometimes it's only a couple of visits, like go work on this tension. And maybe that's a little bit more, there's like a timeline to it. But are you typically working with people a while preoperatively? Is it like one visit assess, maybe one visit treat, and then surgery? And I'm sure it's variable, but what do you typically do?
I was gonna say, it depends.
Yeah, I know.
But right. So in an ideal world, right? Because I am cash based, so I have to keep that in mind. In an ideal world, I would love to see people, just like even with pregnancy and postpartum, I would love to see people, maybe 4 to 6 visits ahead of time, so that we have idea of where your body is. We've gotten some good things for you to work on, and we got these good assessments and interventions in place, so that post-op we are already ready to hit the ground running. Now, it may be to where like, okay, we want to be able to do, so much more post-op that let's conserve. And so we can do 2, maybe 3 visits beforehand. And then now, okay, we're going to really focus in on, let's get these things that you may need, right? Let's go through some of the things that your doctor and your provider are going to give you a list of things you're going to need post-op, but they might not be the same list of things that you need just for yourself personally, right? So they're going to have, you need this to prepare for surgery. You need this like right after, you're going to need this, but it may be some of the little small nuanced things like ice packs, chuck pads, sanitary pads, maybe a walker if we're talking about bottom surgery. If we have a bed that we need to get up and down from, like maybe we need a walker to help with that if it's really low, or something like that. So those may be things that we can look at and see beforehand in those 1 to 2, maybe 3 visits before we have surgery.
Interesting. Okay, that like segues us perfectly into like the really acute, when you see them acutely afterwards, because one of my coworkers was asking me like, oh, what are you going to talk about today, or like who are you going to read? And I told her, and then I was like, I'm assuming that, or like based on some of the stuff that I've read like on your Instagram, I was like, I feel like you can kind of combine pelvic health with inpatient rehab, because you have to potentially do like wound care and bed mobility and like transfers and like all of those, things that like I personally don't do anymore. So tell me more. Okay, so tell me more about like super acute. I guess let's start like how we did like top surgery. So do you see people really acutely for top surgery?
I will, yes, hopefully, yes. If we're able to, yes, absolutely. Because, right, it's the same things, right? We're wound care, absolutely. We want to see what those wounds are looking like. And also, any type of top surgery, we're concerned about lymphedema, right? We want to make sure that there is, the swelling and all the things are going down. We're not looking at any asymmetrical swelling and stuff like that. So when we're talking about top surgery, being able to be in that acute phase of, okay, if you're going to lift, and you've been told not to lift your arms over your head for how many weeks? Well, how do I go to arms over my head? How do I go to putting a stretch on, these scars? And are these scars really healing the way they need to? So acutely, yeah, we want to just go over that. And then how do I cough? How do I breathe? How do I do that bed mobility and adjust, right? Because one of the things that people may not realize is how outpatient some of these surgeries and procedures actually are. Some of them you may be an inpatient and you may be admitted, but depending on what it is, most of the surgeries are outpatient. So you're having top surgery and then you're going home that day or a few hours later. And so while you still have access to your provider and your nurses and all that, um, in that time, you're not in a hospital or in the surgery center in those places. So it is more outpatient. So how do you get home? How do you get in and out of the car to get home? Um, and another component is sometimes there's not that help that's there for these people, right? So if you have someone who can come help you for that day, but you might not have them there for the next day, how do you take care of yourself in that in between time? And then until you have your post-op appointment, like being able to talk about that stuff in the acute phase of you're about to go home or you're about to go back to this apartment that you have to climb 3 steps or 3 stairs to get to. How can you be functional in that and not injure or hurt yourself in any way?
Yeah, no, that makes a lot of sense. How this is a little bit like, I think you could answer this from like a top and bottom surgery perspective, but like you mentioned that it's like I can see how breathing could hurt your pelvic floor, but I'm curious then, like, so do people like tend, like, how does breathing look dysfunctional
Right.
post-operatively? That's what I'm asking. Think about it.
So it's shallow, right? It's very shallow. We're not getting that full kind of breathing into the chest, and I think you can see, but getting that full breathing. So it's shallow and it's protected. So it may be here, right? And so it's just taking the breath, right? Yeah, my hair is covering my shoulders. So right, we're probably more here, and maybe even we're up here, right?
Sure.
So how do we bring everything down? How do we expand and get those full and really stretch? Because we're in a protected phase, so we're trying to not stretch things because it hurts. So how do we get things down and open and a stretch on it with your breathing that's comfortable?
How long does it take maybe to get? I've only done pelvic health. I don't treat any shoulders. I apologize for anyone else that like does that kind of stuff. I'm like, how long does it take to get all your arm motion back?
Well, right. I mean, it could take up to 6 weeks.
No,
right?
that's fair. Yeah.
That's awesome. Yeah, it could take up to 6 weeks, depending on. But sometimes 6 weeks is the time that they're not really wanting you to raise your arms. So some providers are saying not for 6 weeks. So then we're looking at, all right, we may be getting more into like 8 weeks where we're getting full range all the way back. Sure. And now we're comfortable with that stretch on there. So, right. Yeah.
Okay. I was just curious. Okay. And then, so what about, I would assume like a lot of the answer for a top surgery would be the same as a bottom. Like, do you have stairs, like thinking about how they take care of themselves, like that kind of thing. But I guess what else, maybe like, what are you assessing like on them, or what are you looking at for a bottom surgery, like immediately post-operative?
I'm looking at gait for sure. That I would have looked at pre-op if I could have, but I'm looking at gait now because when we're talking about bottom surgery, like I said, depending on the surgery, there may be a thigh flap or a thigh flap that's already in the process of recovering or was recovering. And so how has your gait changed? How are you walking now? And so we're looking at that as well as the tissue, right? We want to see, what do the tissues look like acutely? What do they look like? Are they changing? Any of those like post-op, just like acute care. What is the word I'm looking for? Wound care. Wound care things. What do those tissues look like? And then any types of sensations. Like, do you feel any? Are you feeling any sharp pains, any muscle spasms, anything like that, like just looking at that acutely.
And is that similar? Like, I think like a C-section scar is the one I see the most. So it's like you start massaging that around 6 weeks. Is that similar for like other flaps and stuff like that?
Right. So yeah, when we're looking at that, you may start doing some work if it's really, you notice like it's restrictive, right? So the client that I was assisting, we knew there was already some pelvic floor restriction that we were going to have to consider post-op. And we also knew that there was some hamstring tightness, and then there were some adductor restrictions. And so we started pretty far down, like, okay, let's start in the calf area, just kind of like, how does this feel? Is this comfortable? Let's move up to hamstrings. Can we tolerate this? We started that probably, I would say, a week, maybe,
Oh,
maybe a
yeah.
week, and just like, okay, we know you need to move it. And when I say like, it's like gentle massage and maybe a slight stretch on things, because you need to walk, right? You need to walk, and this is preventing you from walking, or this is preventing you from wanting to sit up or things like that. But also, we know that if we start a little bit further away, then we gradually a little bit closer to the pelvic floor, which then, yeah, let's get into some of the scar massage and slight stretches that are comfortable and safe.
Mm-hmm. No, that makes sense. Um, so immediately post-op then too for bottom surgeries, like is there any other like specific education to that bottom surgery that you're giving them from like a bowel bladder perspective, or anything like that?
Yes, yes. So when we're talking about constipation, right? Anyone who has any type of surgery, right? That anesthesia sucks. And then
Yeah.
any type of pain medication. So constipation is a big one in management. Squatty potty or stool or something that gets the legs up, if it's comfortable and you're able to get in that position. We try to do that, as well as the stool softener, staying on your regimen of stool softeners to help with that. And then breathing techniques for bowel movements for sure, because it's uncomfortable, especially we're doing bottom surgery. So much has been changed, and so many tissues have been I don't want to say traumatized, but that's what they feel like. Um, and so there's been change to those tissues, and so they don't want to stretch, and they don't want that feeling that we get when we need to bear down for or for bowel movement. So constipation is a big one, and then of course, yeah, incontinence can be, depending on the procedure or surgery, it can be something that we're dealing with, and so understanding that just might be where you are right now. Like we may have this incontinence, um, but then we also need to work on control. And there is usually the provider, the surgeon will have a timeline on when they want you to attempt to either have a full stream of urine and to stop it. So they'll have that timeline. And so if after that, they're like, okay, we're removing this catheter at this point, then we want you to attempt to have a full stream and to actually apply the pressure to be able to urinate first, and then now, okay, trying to stop it. So they'll usually have their timeline on that. If you're at that point and it's not, things aren't really happening the way they need to, then okay, how do we re-educate those tissues to be able to start the stream and stop the stream when we need them to?
Yeah, I was gonna say it's like the incontinence people would normally have. Um, is it stress incontinence, or is it like mixed, or is it just like they're leaking all of the time?
It depends, right? So it could be there's leakage that can happen if there is a fistula, or anything that has happened along any of the, if we're thinking about a phallus, or if we're thinking about any like a meta surgery. So
Mhm.
something like that, right? There's a hole that has happened along the lengthening of the urethra, and so now it's just kind of coming out in that place, right? And so
Right.
if that's the case, we can't really do a lot pelvic wise. But we need to know the difference, right? And then there can be that stress incontinence. So if we already went in with a restriction in the pelvic floor, and we knew that that was happening, and then now things are healing and we're still getting restriction, okay, now we may have that stress incontinence that we're noticing with movements, right? Stress, like if we're sitting up, or if we're coughing or sneezing and things like that. So
Mhm.
it can be mixed.
Gotcha. No, that makes sense. That would be like, of course, like it depends and stuff like that. But is it more? like you said, like it sounded like it's more common if you're like also lengthening the urethra. Is that true, or is that like hard to say?
Right. It can be hard to it because when we think about catheter, because even with anatomical male, right, there is a catheter as well. So
Mhm.
it depends, right? It really can it can be not necessarily with the urethral lengthening. Yeah.
Okay. Okay. So basically, not quite sure, or doesn't necessarily mean it will be.
Mhm.
Let's see. I'm trying to think of other acutely post-operative things, but I feel like you answered that. And, oh, by the way, if anyone has questions, you can like we'll have time at the end for them. You can shout them along, and we'll fit them in as we can. But we'll also have like time at the end for questions. But okay. So, do you see then like are most of your patients in the regards of surgery kind of like right before or right after, or do you have some that are like I had surgery 3 years ago and I'm still having this issue, like that kind of thing?
Yeah, so I do get some of that where it's like I've had, I had this and it's been a few years and now I'm still having this pain, or I'm still having
Mhm.
this issue here. Oh no, did I get stuck? Um
Oh,
can you hear me?
we can hear you.
Okay,
Yeah.
okay. It's just very awkward.
I know. I'm like, oh no. I don't know like how to fix that. Like, huh.
Okay. Well, you can still hear me, so that's
Still hear you.
so yeah, so it can be to where it is happening after
Oh, there it goes.
yeah, there we go, back. Where it's years after. That just feels like
Uh-huh.
a blooper type thing.
I know.
Um, where it has been years after surgical procedure, top or bottom. And we're working on mobility. We're still working on scar massage and things like that, because one of the biggest things is like, okay, the scar has laid down. Either we're talking about like the scar has laid down, how it's going to lay down, and I've had this mobility restriction. I just didn't think anything of it,
Mhm.
or maybe they didn't realize their posture has been kind of stuck in whichever way, right? Because if you're adding tissue to the chest, what is your center of balance, and how do how far out do I need to be? And then if you're removing tissue from the chest, then if they've been in these years of binding or having taping down and things like that, how then do we become okay with opening in a way that doesn't feel like I'm just exposing everything? uh,
Yeah.
so that and that takes a little bit of time because you've been doing this for years now, and so how do we unlearn that and retrain the body and our mechanisms around that?
Yeah. I guess I'm curious too, then, like, I guess in general, what are like symptoms that you've kind of mentioned them, but just like collectively, like, what symptoms do you typically see after surgery? Like, I would assume pain. We talked about leakage, but yeah, other like any other like typical symptoms that you usually see post-op, regardless of how long it's been.
Yeah, muscle spasms are a big one. Muscle spasms that can happen acutely, but that can also still be happening afterwards,
Mhm.
where it's like, oh, I just thought this was just like a random little thing that just happened. So muscle spasms can be happening, and working on helping to release and any restrictions in there. Um, and then, of course, anything after. So depending on let's see. I had my notes down, but then I got lost.
I know, I
Yeah,
hear
so
that.
posture, right? Posture, rib cage mobility,
Mhm.
any type of abdominal, right? So that's the other thing, right? We want to look at the abdomen. And I know we talked about top, we talked about bottom, but like that's that middle part that isn't
Yeah.
necessarily um, forgotten either, because there are some procedures and surgeries that you can do for reshaping, right? So there are things that you can do. So if anatomical female at birth, um, looking to have any type of procedures, there are some reshaping procedures that can be done to decrease the width of the hips or any tissue that's there.
Is
And
that
so,
like lipo or?
yeah, similar. Yeah,
Yeah.
really.
Yeah.
And so, even thinking of stuff like that, so where there may be these abdominal incisions and adhesions and things like that, that now we're working through.
Okay, that's interesting. I mean, yeah, I would assume it's a lot of like abdominal tension, like working on the breathing and like that kind of thing. Are there other procedures that, like we talked about surgeries, but other procedures that you see besides like the reshaping of the abdomen?
Um, Not that I can think of off the top of my head.
Oh no, yeah. I mean, like, I don't know what else it would be, but I'm curious. Let's see. Okay, so you mentioned like the early, like, do you see anyone like you see people a week post-op? Is that pretty, like in a perfect world, like that's pretty standard?
Yeah, so with the patient that I was assisting when I came to Lady Bird and we
Yeah.
actually set all this stuff up,
Uh-huh.
I saw them like immediately post-op, which is rare. I do know that's rare. Unless you're in acute care, that may not be. But in outpatient setting, yeah, probably like a week I would say is probably normal. But
Mhm.
immediately after, it's so nice. It is so nice to just be able to see like the change even from, this is what things look like hours afterwards versus like this is what it looks like in a week. And it looks so different and things look great.
Yeah, that's
But
amazing.
yeah, so I would say like a week is pretty great.
Mhm.
Anywhere from like a week to maybe 4 to 6 weeks, right? When it's like, okay, you are okay to do things. Now you can go back and, maybe do some therapy as well.
Yeah, that makes sense. Okay. Well, all right. I have a like kind of non-surgery related question, but then it just feels like you would also deal with it if someone was having surgery. But I'm curious, like your role or like a PT's role or therapist role, maybe it's OT, and like hormones in regards to like gender affirming care. Cause like obviously I know medication's like kind of tricky, but like I recommend topical estrogen constantly to people who need it. So it's like, yeah, it's like I would feel comfortable talking about it, but what are your thoughts on that, basically?
Oh, I'm glad. When you had that question, I'm so glad because
Oh,
you're
good.
right. Like we clearly have a role as therapists in hormone replacement, hormone therapies, because yeah, we recommend topical estrogen all the time. Um, Topical estrogen, or as well as like if birth control is appropriate, or so we have a say, and we assist people in hormone therapies all the time. It is not very different when we're talking about gender affirming care, right? The only difference is we do need to just, okay, we know that our general things that whether it's anatomical female, anatomical male, that those tissues are going to respond to introduction of um, testosterone or estrogen, or some type of hormone, right? So if we're talking about anatomical female at birth, but we're introducing testosterone, we know that, okay, there could be some clitoral length change. There could be some vaginal canal dryness associated with it. Same thing as anatomical male at birth when we're introducing estrogen. And I'm stuck again. I'm sorry. Maybe it's the internet here.
Oh, I'm so sorry.
Um,
No problem.
but okay,
You can
I'll just
mute.
keep going. Any type of anatomical male at birth introducing estrogen, we know there could be that soreness in places and mood changes and stuff like that. So we do have a role in understanding that part of it of what hormone therapy can look like. And so it's really similar to how we are like, okay, this the biggest thing is like we can be that voice that's saying what you're describing to me is a normal response to these tissues having this hormone.
Mhm.
However, for you, maybe it's too much of this hormone, maybe it's too little of this hormone, or maybe it's the complete wrong hormone, and we need to just work on a different method. And that's when we collaborate with the provider and we, give our assessment, and this is what we think might be going on, and how that can help with that, as well as being a resource for a patient because maybe they just moved here or maybe they just don't know who to go to, right? But that
You're like
this,
the only person they're talking to about this. Like
yes,
we're
right,
PCP all the time, I
right.
think. Yeah, for sure.
So yeah, being
Well,
that resource for sure.
yeah. No, then I'm curious, like, okay, so I like am thinking like how do I recommend topical estrogen? I look at the vulva, I do a Q-tip test, like of course, like there's subjective things. What I don't know. I guess like what are you basing your recommendations off of? Because like I don't do that as like for systemic hormones very often. So I'm curious
Right.
what cues you into different hormonal changes.
Right. So, right, it's going through that same assessment, right? Seeing if it's a tissue thing and assessing that. However, the standards of care, that's going back to the W path and the standards of,
Um,
right? So if you're saying, okay, this is what you're doing, this is where you're at, these are the things that we're expecting in your transition or in your process. So we know that this is a hormone that you're taking. Standards of care, this is kind of what the outline is, right? And so again, it may not be to where I'm specifically saying you need to be taking this dosage of it, but based off maybe what I've seen or what I know can happen with testosterone or estrogen, this doesn't necessarily seem correct for you. So then we're recommendation to go back to the provider and then they can figure, do the dosage.
yeah. So you have like the standard of care. Was it like W path, like PAC?
WPATH.
Okay, WPH, and there's the standards of care, and so you're kind of thinking or looking, and it's like, I don't know, like week 2 through 4, like these are typical symptoms or presentations, and so when it doesn't match, you can kind of like cross-reference and make a recommendation. Like, is that right?
Right. So having our ideas of like what we know is kind of expected, but then so then standards of care, this is where or dosage that someone should be on or something like that. And
Oh,
if they've told you that maybe they're on a different one and you've seen that and you saw that, well, that might not be, but you're not the one saying you need to be on a different dosage, right? You're saying based off of all the things, maybe we need to go back to your provider and see if that is dosage appropriate for you,
got it. Okay, that
or
makes sense.
or this administration, right? Because we can administer testosterone through injection. We could do a topical, so there's different ways that you can do it. So maybe talking with them and seeing what your options are if that's appropriate for you.
That makes sense. Okay, it makes sense. Like the dosages are on there, and so if that's different, yeah.
Yeah.
Okay. No, that's cool. That's interesting. Let's see other hormone questions because that's so fascinating. Let me see. Anything else about like hormones and like what your role is, either preoperatively or like how you help them with that?
Yeah, I mean, the biggest thing is if you don't feel comfortable with that, but there is a provider who can help with it, just being that resource, like, okay, I'm not 100% sure what's going on with it, but it doesn't seem accurate or whatever a better term is. And so, but being able to just be a resource and refer them to someone who can help them kind of go through it because it can be tricky. Hormone therapy, we know in general, like when we're talking about pregnancy, postpartum, menopause, like hormone therapy can be just, I mean, variable all over the place. And so it's really tough to say, well, this should be working for you, or you shouldn't be having these problems, or, your levels are at this place and you've been tested every, 3 or 4 months like you're supposed to. But still, this, while we might be able to say that this should not be, or this, couldn't be something that's going on, every person is different. And so being able to say, like, okay, I'm not, this just doesn't seem right to me, but let's get another person's opinion on it and how can we help with this.
Yeah, that makes sense. Well, what about, is there anything else that you wish like a person that's like, thinking about like a gender affirming surgery or a therapist that's like thinking about working with this well, actually, let's go. Yeah, let's go more patients. Right? What do you wish like more patients knew that were going under like a surgery?
I wish they knew that pelvic PT can assist with it. That just in general about everything, right? Pelvic PT needs to be for everybody. Everyone needs a pelvic PT, or pelvic therapist. But for gender affirming surgeries and procedure for sure, just how helpful it can be in the process and recovery afterwards. Because it's being able to prepare for the procedure and things that you don't know what you don't know.
Yeah.
So having someone that's, can be there and say, well, have you considered this point? Have you considered this point? Right? Because we have all these, if an ideal world, things that can happen, but if that doesn't happen, then what? Right? If this person isn't able to stay with you for 2 weeks, and then what? And so just being able to know that there is help outside of your surgeons and other providers, maybe cares, because it's tough, right? Because this is a protected community and a protective community, because it can be dangerous to live in your true self. And so being able to understand that, okay, there are people who can help me outside of the surgeons and the other primary cares.
Yeah, absolutely. That's cool. Okay, well, what about for like a pelvic therapist? Anything that, like, if someone's interested, it's maybe where to start, like whether that's a course or like any advice.
Yes. So I would start for sure with, like I said, I took the gender affirming course through the APTA, but I think they have it through Herman and Wallace as well. And it's specific for pelvic therapy. So that makes a big difference as well. So that's kind of like step one. WPATH was, for me, open so much for me, because it was just like, okay, these are standards of care. Like, you can tell and you can see, and in so many places does it say pelvic floor physical therapy can help with these things. So it's like, okay, they understand and recognize the importance of it, but
Yeah.
also the whole network of other providers who are like, hey, I have this person, this is happening, and you're like, oh, I know that's they need to go to pelvic PT, or I know that's because maybe they actually need to see this person, right? And so having that is really awesome as well. So I would say, like, that's kind of like the first steps. And now I understand WPATH is a whole like membership and things like that. And they have to approve you. And so while that is a nice thing to have, if you don't have that, you can still do the research and all the other stuff, and still be able to provide the care outside of that. One of the other biggest things is knowing and understanding pronouns, because it's a tough one, right? Especially if you're not familiar with them, or if you slip up. The biggest thing is, like, be okay with making mistakes, right? Be okay with it and owning them and understanding it, but that is not anything malicious. It's kind of the biggest thing. Like, your intent is to affirm whomever you are treating, and so be able to do that in a way that they understand, and feel safe and comfortable with.
Yeah.
Um, the other thing is documentation. It's a tough one. It's a tough one. So I hear Rose Pelvic Physiotherapy. I don't have separate documentation for any of my people, really. Everyone gets the same form, because I asked about testosterone. We know that anatomical female at birth can be taking testosterone. So if I'm not asking about that, and I'm just assuming, like, oh, this is a woman and this is a man, and I give them these separate documents, well, I'm missing out on that question as well. Same thing as people don't necessarily have to disclose to you whether they are trans or non-binary. And so if you're not asking questions on pregnancies and any type of C-section or anything to other people, if you have an anatomical male presenting patient, however, they've carried a pregnancy, you're going to miss out on that information. So being able to have that in a way that anyone can answer those questions, regardless of how they may be appearing, is pretty important. But
And
yeah,
that's just very like creating like a safe space for your people. And that's like the pronoun thing is like trauma informed care to me. It's like it's creating a safe space for someone to tell you that you made them feel unsafe, and knowing that you are going to trigger someone because you're not going to know what's
right.
like to them. But it's like creating that safe space so that they can tell you and that you can address it and stuff. So yeah, it's huge.
Glad you, yes, trauma informed. Absolutely. That is like, that's a whole nother, right?
Oh, I know. I know. It's like, oh, go check out Christina Holland's Instagram. She's like my little idol. I love her. But okay, I'll tell you what. Okay, I'm gonna open up the floor to questions, and so you can type them in the chat box. You can type them in the Q&A. We'll give some people some time to do that. But yeah, while people are thinking of questions, let me think of something now. Anything else? This has been so freaking fun. I cannot believe it's been 52 minutes. I'm like, whoa, like it just flew by. That was.
I feel like I've been talking for so long.
I bet you did.
No, just kidding. Just kidding.
I'm just asking questions.
Like, I go home and my husband's probably gonna be so happy because he's like, oh, good, you got all your words out for the day. Because he swears I have a quota of how many words I need to say every day.
There you go. That's a good one. That's awesome. Well, see, I always get really riled up when I do interviews like this. Like, I'm all like excited afterwards, and so I like go home with like a bunch of energy. So Greta's not home, but she'll probably be like, actually, she'll be really excited. So my wife used to be a pelvic floor PT, so she loves this stuff. But okay, I'm gonna read the question out. Okay, so how do you do direct dilator use following surgery for male to female bottom surgeries?
Oh, yes. How did I forget dilator use? Yes. So the biggest thing, so there usually the surgeon may have a protocol, right, that they have, or they're like, okay, you're doing this dilator, and I don't have any of the dilators that they use for male to female bottom surgery. We're talking about vaginoplasty, but they may have a protocol that they use that might not be appropriate for your patient. So being okay with, like, okay, we're not going to say, well, your surgeon's terrible, right? No, we're gonna say this may not be an appropriate protocol for you. So while they may be telling you that you need to move up in size to a larger dilator, or at this point, or you need to be having this depth with the dilator, it may not be where they are. And we don't want to force things, because when we know that if we are making something an overwhelming, people might not do it. And we know with the directed dilator use is lifelong. So they will need to use dilators for the rest of their life. And so how can we make it a way that they feel comfortable using it, hitting it? So yes, the protocol, they usually give you a protocol, but being able to know that we may have to adjust it slightly, right? Because we do know that there needs to be a certain amount of depth that we're reaching and a certain amount of dilation that we're reaching too. So yes, that would be how we do it, just kind of making it appropriate for that person.
Is that like usually if you have to adjust it, it's like people are going to like the protocol is too quick, like it's too painful to do. Is
Right,
that you?
right. Yeah, it's
Okay.
like slow it down a little bit. And then positioning. Positioning is a big one. Understanding, right, we don't want to be in a position where we're activating the pelvic muscles, or we're activating the abdomen, and we're kind of sitting up and trying to do it, being able to be reclined in a position, and then finding comfortable areas. If we need to use pillows to put brace on the legs, we can use that. But yeah, positioning is also a big one too. Too. Okay, yeah. So like I said, for each surgeon may have a protocol, um, but we can you can kind of adjust it, and there is like a just a general protocol. You might be like, okay, let's see if this is appropriate for you. But yeah, usually you're kind of following what each individual surgeon is saying, because we want to make sure they're not upset at us. Jessica, I think your microphone is off.
It was. So
There
sorry.
we go.
Okay. I popped and turn back on. Okay, so how long do you attempt dilator use if you're not seeing progress before directing back to the surgeon for potential revision?
Mm. Well, you don't want to do, you really don't want to do a revision. We really want to try to avoid that. So if it's true, like, okay, we're being really compliant with it, we've really gone through all the positionings, we've kind of gone down to foundations, we really are just kind of at the tip of the smallest one, and we're really not able to tolerate it. We've kind of looked at other pelvic floor things around it, hips, adductors, glute, right? We've looked at all the things around it. We're going to give it we're going to give it everything we have in our pelvic floor, physical therapy, occupational therapy, whatever toolboxes we have, we've given it everything. Then yeah, let's send them back to the surgeon and tell them we've given it everything we've done. So the timeline on that, I haven't had to do that. Right, because we don't want a revision. But if it does get to that point where it's like, okay, we are 12 weeks, 6 months out, and we're still not able to get to to be getting to, yeah, we really need to reassess and reevaluate.
Yeah, that makes sense. Okay, I'll read the next one. What are the treatment guidelines for training pelvic floor muscle to encourage comfortable voiding after urethral lengthening, female to male post-op?
What are the treatment guidelines for retraining after urethral lengthening? So female to male, right? Post-op scenario. The catheter is coming out, and sometimes it really is just like it cannot be controlled. The body's like, I want to get back to this. I'm tired of this catheter. And it really does just kind of kick right in, and we're able to do it. So that is great. That's what we want. Sometimes not so much. And so we're going into some of those retraining things where we're thinking of, okay, we know that we need to open, the urethra is now longer. And so maybe that sensation is a little bit different. And so we're training on what are those tissues doing around? Do we need to release any of them? Do we need to do any visualization where we're actively sitting here and we're trying to feel that sensation and try to get the opening? Yes, I want to make sure I'm actually answering the question. Did that answer the question? To encourage voiding after.
I think so, like pelvic floor relaxation, but like you could mention like either visualizing or whether that's like breathing and like things like that. That's what I understood.
Yes, sitting might be one of the solutions as well. Okay.
Yeah. Perfect. Oh, but then her next one is like, are there any sensory considerations during urethral muscle training?
Yes, right. So if we have any of those muscle spasms or any of those, right, because the nerves in that area, when we're thinking about pelvic bottom surgeries, those nerves in the area. So right now, the patient that I'm working with, he's having some random itching. And it's not surface at all. And we can pinpoint an area where it goes away. And so we know it's sensory, we know it's nerve regeneration. And so at first he was like, I don't have an STI, I promise. And I was like, that's good to know. Right. So, but it can present that way. So sensory for sure, understanding and knowing what those sensory things can be, the burning, the random sharp pains, right? The general sensory things that we think of can happen in that area when we're talking about those urethral muscles and things like that. So the itching it did throw me off really quickly. I was like, what the heck? And I was like, oh, no. Okay, I know this.
Yeah. Was it like, excuse me, at the urethra, or where was the itching?
So it was pubic. So it was adjacent. So it was right next to it. However, It was so close that I was concerned, because I was like, are you sure you didn't, you of course you go through any type of topical stuff. I was like, you're sure it's not topical? I was like, I cannot scratch it. But we literally were able to palpate, and I anatomy wise, right in the pubic area, but right next to it, and then just applying that pressure, and it went away. And then and off. And so then even if I went a little bit higher, it was able to decrease it too.
Interesting. That's crazy. Okay, let's see. Any approximate timeline for sensory changes to desensitize? Yeah.
No, I'm not really sure on that. And like right now so this was October, we're 3 months, and we're still dealing with some of the sensory things right now. 6 months, really when we think about nerve regeneration and things like that, we really have to just consider that, but understand, like, yeah, those can be part of it. And one of the things I did, now we're working on, is different textures. So now we're doing a rough towel, we're using a loofah, just different textures to be able to ease back into sensory and sensations.
I know, I was trying to think like the closest thing. I'm like, how long could it take a C-section scar? That's what my mind.
Yeah.
So it's like so hard like to know.
My
now you're on Mattis. We can still hear you. I don't know. But yeah, what diagnosis codes do you typically use pre-op?
Diagnosis codes. I'm still using, and I'm cash based, so I'm like.
Like just spasm and weakness. That's what I would.
Yeah. that's what I mean. Maybe if we have some hip pain, I like need that. But yeah, nothing specific.
That's fair. I guess it depends on like referrals and stuff. But okay, any other questions?
I love this.
I know, these are good questions. I'm like, oh, cool.
Feels like I'm so glad, because how did I completely get dilation? Like, oh my god.
That's funny. It wasn't part of it either. I don't know why. I was like, Yeah, I don't know if in my mind, honestly, I was like, it felt like it was such a vast undertaking that I was like, that's next time.
Yeah,
We're just,
no, next time, yes.
yeah, but maybe next time we can go over more dilation specific things. But the hard part is like this really, like we said, it like truly could be like 3 to 4 like webinars because there's so much like nitty gritty stuff to like talk about. This is like its whole own field. It's like trying to cover like just C-section recovery or like just leak, it's like in one, it's like, no, some of the basics, but it's like, there's so much. So I'm sure there's lots of other things that we could talk about too. But okay. All right. Well, I will stop it there. Thank you so much for like being here and like talking to me today. Like I've learned so much. This is like so freaking cool and interesting. Super, super fun. So thank you. Thank you.
Thank you for all the questions and then just all the things and organizing all this because you are awesome. And Rebecca, because she was like, hey, this would be a great idea. I was like, oh, you're right. You're so smart. So I'm so grateful to y'all at Ladybird PT. And then of course for you for putting all this stuff together. And good. And I'm glad the information was good, even though we skipped a couple things and y'all had to ask me about it. But I am working to put out more information, especially for gender affirming care and surgeries. I put out some stuff and I try to make things just as kind of inclusive for everything, but I do understand the importance of specifically talking through some of this stuff. So y'all have given me some wonderful things that I think I need to go out and just like specifically target and do some content for. But yeah,
what's your like social media stuff if they want to like follow you and stuff?
You can follow me at Rose Pelvic Physiotherapy on Instagram. I know it's really long. I can put it in the chat if we want to do that. But it's also all the things. But yes, it is Rose Pelvic Physiotherapy. You can check out the website at rosepelvicphysio.com. I shortened it for my website. And then we are on YouTube too, which is where I post a lot of my longer videos where I can go through stuff in a lot more detail because I like to talk. That's my thing.
Feel that. Okay, love it. All right, okay, I'm gonna stop recording, but again, thank you.